Good morning, everybody. Welcome to Grand Rounds. Pablo, I know you're a marathon runner and you love to stand and burn those calories, but there are seats up here if you want to come. Next week, our Grand Round speaker will be one of our own faculty, Michael Grunbaum, who will be talking about what's kind of the fast expanding use of ketamine for clinical applications. And the title of the presentation was Listening to Ketamine Clinical Trials for Suicidal Ideation and Next Steps. I don't have any announcements really other than to say that, is Stroop here? No. Anyway, there's, so Reuters does a highly cited researchers ranking that comes out, and Reuters, I guess, got acquired by some company that calls itself Clariot. Anybody know about this stuff? Well, it comes out in emails, and I think we've tweeted out this, so if you follow the Columbia Psychiatry Twitter feed, you'll see it. At any rate, they came out with this year's highly cited researchers, and a bunch of us were on it. Columbia Psychiatry was very well represented, which is pretty good, because that's like, one of the most significant metrics on impact of faculty on a field of any medical discipline. So look at that, and these rankings are often beauty contests, but this is one that actually has some validity to it. So today, our speaker is one of our own faculty, Elizabeth Betsy Fitelson. And Betsy is somebody that we wanted to speak because she represents our aspirational efforts, which not always are successful in the immediate or short term, but because of the scientific opportunity, the public health need, we persevere in an effort to address it as best we can, and hopefully in increasing ways, and that has to do with really women's mental health. The services we're able to provide within our clinical systems, state, university, hospital, are all constrained by those financing mechanisms and the infrastructure of those. And when you see things that have to be done, whether it's learning disabilities, whether it's autism, whether it's youth mental health, LGBT populations, substance abuse, we have to do it in a way which develops these programs in a way that's financially viable, as well as supporting the training and research opportunities. So we've been working to try and develop and expanding our women's mental health programs for some number of years, and to be candid, it has been, I don't know if you're going to talk about this, it has been challenging simply because of the difficulty in getting adequate financial support from our various sources. Nevertheless, Betsy, more than anyone else, Betsy and Catherine Monk really have been leading this effort and have engaged in the process a number of faculty who have a long-standing interest in this, such as Margaret Spinelli, and also trainees who have an interest in this area, which is a very popular one. And I think Mayumi has been one, and Uju has been another, and anybody else?
Well, many who have moved on, Alison Herman, Lauren Osborne.
Right. Lauren Osborne is now head of women's mental health at Hopkins, right? Okay. So, we're generating some faculty who are contributing to this workforce. At any rate, Betsy's our person in this regard, and we thought it was high time that she present on the work that's being done. Just by way of background, Betsy went to undergraduate school at Princeton. She was an athlete. She rode crew, which by my reading of the sports physiology literature is from a standpoint of just sheer endurance and physical pain is even more than marathon running, Pablo, is the most taxing. And then she came to Columbia for medical school, did her residency here. You were a chief resident?
No, I wasn't.
she wasn't a chief resident because she didn't want the administrative burden. She started the women's program instead. That was good judgment. And is currently an assistant professor and leading the women's mental health program, and particularly also the innovative program in domestic violence, or providing mental health care to victims of domestic violence. And we'll be talking about mental health, maternal mental health, the clinician's perspective. So just one last comment by way of complaining. The ACOG, American College of Obstetrics and Gynecology, was it last January, mandated that screening be done in perinatal clinics, and because the evidence clearly supported it. And if you polled all of even the best medical institutions around the country, I doubt that the majority of them would have that in place. But at any rate, Betsy's going to tell us about what we've been doing here and her thoughts about that area in general. So please welcome Dr. Betsy Fitelson.
Thank you, Jeff, and thanks, everyone. It's really an honor to be up here speaking to you about this topic. It's also a little bit intimidating because in the last 6 months, we've had Kathy Wisner here, who's really one of the world's experts in maternal mental health and perinatal mental health, giving an update on medications in pregnancy. And we've had Donna Stewart in the last month, who's another world's expert on maternal mental health and the intersection of mental health and domestic violence. So that's pretty much what I do. So when I found out I was giving grand rounds now, I said, oh, well, I'll figure something else to talk about. First, let me express my gratitude to the Chapman-Perlman Foundation, the Left Fund, and the Terry Satsuki Millhub Fund, who have been very supportive of maternal efforts in maternal mental health. And also just point out that no psychotropic medications currently have an FDA indication for use in pregnancy and lactation. So as I was tossing and turning, thinking about what to talk about, we saw a case in the Medicaid clinic, in the adult outpatient clinic with my wonderful colleagues over at I6. And this case made me think about that perhaps I do have a few things to say, in part because she's such a remarkable case, and in part because she's such a sort of usual case that we see there. So this is Miss M. She's a 24-year-old Dominican-American single mother of a 5-year-old daughter. She works in a low-level clerical position at a major corporation and has a high school education, although she has taken some college credits. She has private health insurance through her union, although has to travel from Manhattan to Queens to find a psychiatrist who accepts it. She has a history of childhood sexual abuse and neglect. She was in a domestic violence relationship at age 19 with the father of her 5-year-old daughter, the father is no longer in her life or her daughter's life. She has a history, she's currently in a supportive relationship with a man who's 10 years older. She has a history of major depressive disorder with 3 prior psychiatric hospitalizations and 1 aborted suicide attempt. She presented to our clinic after a frantic call from an obstetrician at 8 weeks pregnant with profound worsening of her depression and anxiety symptoms. It turns out that she had been somewhat ambivalent about pregnancy. Her partner wanted her to get pregnant. She wanted to continue in school, wasn't sure she could do that, but they weren't using precautions, and so she got pregnant. She called her psychiatrist, who said, stop your medications, and if you continue the pregnancy, I can't treat you. So in that context, she stopped her medication. She became increasingly profoundly depressed and anxious to the point that by the time we saw her, she was psychomotor retarded. She couldn't function. She couldn't work. She was having passive suicidal ideation, although her daughter remained a strong supportive factor. And we ended up having to hospitalize her. So this case actually made me think about a presentation I saw by Dr. Kamara Jones at this year's IPS conference. If any of you don't know who Dr. Jones is, she's an internist and an epidemiologist, and she gives brilliant analogies about the social determinants of health and health equity. And I would look up her TED Talk, but this is her cliff analogy. So this is the cliff of good health. And you can think of the ambulance as the clinical care for patients who are sick. This is our secondary prevention measures. This fence here, preventing people from falling off the cliff and down to getting sick and needing care, can represent primary prevention measures. But of course, you really want people not to get too close to the cliff at all. And what are these factors here that would determine how close people are to the cliff or not? This space represents the social determinants of health. But you can also notice that this is a three-dimensional cliff, and some people are starting off closer to the edge of the cliff, where there isn't a fence and may or may not be any services down below. This difference represents the differences in health equity. So this made me think about my patient and where she sat in this three-dimensional plane, how she initially fell off the cliff, how she got back up to here, where she was in a stable relationship, working, taking care of her daughter, and why this pregnancy made her fall so far, so fast back down. So most of us sit down here, where the ambulance is, treating our patients. So from the clinician's perspective, looking up and seeing patients falling down, it really makes me think, well, what are the factors that let our patients fall off this cliff? And what can we do from here to help patients get back up here? And then what can we do, what ladder can we climb here and help them get back up on the cliff? So I'm going to talk today about why an understanding of maternal mental health is important. Why is the perinatal period a high-risk time for psychiatric illness in terms of its course and morbidity? How can we use this knowledge to make informed treatment decisions for our patients? And what else can we do for our patients who are parents? So the first question, why is understanding maternal mental health important? I'll start off with some basic statistics. So 86% of US women have at least one child by the age of 44. And if you think that there are far more pregnancies than there are children, there's a lot of pregnancies. Approximately 50% of pregnancies are unplanned. So I'll let you do the math, and then you can think about whether you're going to be facing some of these issues with any of your patients between the ages of female patients between the ages of 14 and 55. So it's an issue that affects all of us who treat female patients. There's also a lot of prescribing that's going on now. In one study, among privately insured women in 2006 to 2011, roughly 10% received at least one prescription for a psychotropic medication during pregnancy, with a lot of variance between states. 5% were antidepressants, 3.5% were hypnotics or benzodiazepines, mostly zolpidem, and 1.6% of all these women had more than one category of psychotropic. Rates in the medicated population are likely higher. This study with 8% of women having been dispensed an antidepressant medication was from Tennessee. Most women in both the privately insured and the Medicaid populations stopped their medications in the first trimester. However, a significant group also started medications newly in pregnancy as well. So another reason understanding maternal mental health is important is that maternal well-being is critical for children's physical, cognitive, and emotional development. I'll talk a little bit about that, and then I'll flash a slide about the fetal origins of health and disease, but that's a whole lecture series in and of itself, which I've been so grateful to have such wonderful colleagues explain it to me. Many of you are familiar with the work of our wonderful colleague Beatrice Beebe, looking at that dance of attachment between mother and child. And we know that maternal mental illness can significantly affect the interactions between mother and child. And in fact, I can see it. I've treated mostly perinatal women for my entire career. I've gotten pretty good at this point at treating depression and anxiety disorders. I can treat the psychiatric symptoms. But oftentimes, what's left in the room when mom is there with her baby is this dysregulation of attachment. And I can see it in front of me. And oftentimes where that's coming from is the trauma, the trauma, the stress, the social determinants of health that we're on that cliff. So it's critically important that we do what we can to both prevent women from falling off that cliff and developing symptoms, and to do our best to treat the symptoms for her sake and for the sake of her children. We also know from Myrna Weissman's work that psychological well-being is also critical for their children later on. In the STAR*D trial, when they looked at mother and child pairs, mothers with depression, the children had higher rates of psychiatric morbidity. When they looked at the group of women who had recovered from depression and compared to the mother-child dyads whose mothers did not recover from depression, the children of the mothers who recovered from depression, who remitted, improved without any direct intervention with the children. The children of the mothers whose depression did not remit got worse. Oh, Myrna, you walked in the door just as I was talking about your study. So maternal mental health is important for all of our children in an ongoing way.
Betsy, can I ask
Yes.
for a clarification? When you talk about, the attachment thing and in the absence of, a definable diagnostic condition.
Yes.
That there's some dysregulation of attachment due to the exposures and traumas. Are you talking about, individuals that are having children for the first time and the adjustment they have to make, or individuals that have traumatic experience from poverty or domestic violence or other things in their life?
I'm sorry, Jeff, are you asking about whether the trauma is from the childbearing or the general trauma?
Yeah, it depends on how you define trauma. So, for example, just the fact of a married couple or even an unmarried couple having a first child is traumatic because you're experiencing a whole new way of life and stresses and so on. Are you referring to that, or are you talking about what is more clinically defined as trauma as?
Most of what I'm talking about would be more significant, what I'd call developmental trauma in many of the patients that we see.
Earlier in their lives.
Yes, so like the patient I talked about, Ms. M, who had a history of childhood sexual abuse and emotional neglect, and then domestic violence, as well as financial stresses, educational stresses, sort of this piling on of trauma that profoundly affected her relationships and her attachments in an ongoing way. That said, the drama and trauma of childbearing childbearing itself can be traumatic. I don't talk about it so much in this talk, but there are, I'll touch on it a little bit, but childbirth in this country can be traumatic, and women can actually suffer from traumatic symptoms, post-traumatic symptoms with it. So there's a lot of research now, some of which is done by some of my wonderful colleagues in this room, about the fetal origins of health and disease. I stumbled upon this graphic with the label, "When you're pregnant, you're also pregnant with your grandchild," which just made me feel like, oh, the pressure, really. But it is true, and it's really important. And so thinking about exercise, a healthy diet, and low stress as really healthy for children, that's a wonderful thing. However, that is not what our patients experience. Almost by definition, the patients we see with psychiatric issues have difficulty with all or some of these factors. This slide, I'm grateful to Catherine Monk for lending me, and this, as I said, is probably a 6-month course in and of itself. But if you think about psychological distress as itself a toxic exposure, and psychological distress can come from external stresses, a natural disaster, a terrorist attack, poverty, et cetera, and internal stresses. So the state of being depressed or highly anxious in pregnancy is itself a form of psychological distress that is itself a toxic exposure that interacts in complex ways with the fetus, with the placenta, the fetus, and the child through molecular and hormonal and epigenetic ways. So this is really a work in progress, but it's really just in the last 10 years, I think, that the progress in understanding what it means, what the effects of stress on pregnancy mean, is really so critical. Also, from a public health perspective, pregnancy and childbearing is what I would call sort of a stress test of the individual in terms of her health and mental health, the family system, our social system, and our healthcare system, which is part of why maternal health in general is considered one of the critical markers of a society's health. Also, In the perinatal period, women have repeated interactions with the healthcare system, which presents an opportunity to intervene before families fall off the cliff. There's very few other times where someone will have this many interactions, otherwise healthy families will have this many interactions with the healthcare system. So it's both a stressor and a moment of opportunity. So if maternal health is a critical marker for the health of a society, how are we doing? We are not doing very well. So I don't know if any of you have been following this, but the maternal mortality ratio in this country has been steadily rising. That's in contrast to most of the developed countries and developing countries in the world where the maternal mortality ratios have been decreasing. This difference, so our maternal mortality ratio is 18. To give you a counterpoint, in the UK, it's eight maternal deaths per 100,000 live births. Ours is 18 for the whole population. For white women, that number is 12.1 per 100,000. For for Black women, it's 40 per 100,000, and for other ethnicities, it's 16.4. So I would also encourage you to take a look at the this ProPublica series and the NPR series on this topic that talks about the health disparities and maternal mortality. This year, I've had the privilege of sitting on the Maternal Mortality Review Committee for New York City, where we review all of the maternal deaths in a given year and look at the different factors involved. And I can tell you that the maternal mortality ratio, even as high as it is an underestimate of the total maternal deaths and significantly underestimates the mental health component contribution to maternal deaths. So most of those numbers are looking at what are defined as pregnancy-related mortality. So that's the cause of death is on the death certificate as a direct maternal cause, a direct obstetric cause of death. That will not get many of the suicides, overdoses, and homicides that are under the rubric of pregnancy-associated or all-cause maternal mortality. Even so, even with the pregnancy-related deaths, 6.5 of pregnancy-related deaths were suicide. Mental health conditions contributed to about 13%, and substance use disorders contributed to 8.2%. We all know that the opiate epidemic is claiming more lives than ever, and it's claiming women's lives and mothers' lives as well. Between 2007 and 2012, on average, 21,000 pregnant women misused opiates in the past month. Misuse rates were higher in ages 15 to 17 and 18 to 25, and more common among those living below poverty. Of the 21,000 admissions for opiate use treatment, 23% were using heroin and 28% non-heroin opiates. And of 13 outpatient or residential programs, only 13% of outpatient or residential programs and 7% of inpatient programs offer specialized treatment for pregnant women. This is a problem we're seeing here in this hospital, and with no place to send these women. So this is a study that actually gets at some of the psychiatric morbidity, where if you look at the rates of pregnancy-associated all-cause maternal mortality, homicide is actually the number one cause of maternal deaths during pregnancy or within the first year postpartum, followed by suicide. And that is higher than the rates of each individual obstetric complication. It's also important to note that in more than half of the pregnancy-associated suicides, there was evidence of intimate partner violence. So IPV, as we learned from Dr. Stewart last month, IPV may decrease, increase, or begin during pregnancy. It's not necessarily protective as we would hope it would be. Patterns of IPV in the site of injury may change. In fact, there was one, I was called to do a consultation on the inpatient unit. This was about a year and a half ago. And it was for a consultation about the medications in pregnancy. But when I talked to the team, this woman was in an abusive relationship. And the team told me, well, it's okay. She says he stopped hitting her. He just chokes her once in a while. So if you were here for Dr. Stewart's talk, you will understand that, in fact, both ongoing abuse in pregnancy and strangulation have their own significant morbidity and are a marker for risk of homicide in the future. Women who experience IPV during pregnancy report higher frequencies of severe IPV, and women who experience IPV during pregnancy are at greater risk for being killed by their partners, compared to women who experience IPV outside of pregnancy. And I point this out because this is a mental health issue. We will see many of these women in our clinics, and if we don't ask them what's going on with their relationships, we will miss this whole part of their lives. Finally, I've always loved this picture. I think I took this as clip art, 15 years ago or something, because it sort of encapsulates what I imagined pregnancy was going to be like, right? This beautiful woman in the lotus position, staring down at her belly in rapture. She's in some elevated, isolated space, and it just looks lovely. That was not what my pregnancy looked like. It's not what most pregnancies look like, sadly. But we still have this. This is still in our collective psyche as what it should be. And that actually contributes to stigma, to cultural bias, and a lot of wishful thinking that affects us. So, and this actually has, also we see this bias in the news, right? We hear about maternal mental health when some beautiful women have recovered beautifully from depression and speak beautifully about it. And we are able to empathize with them. And I'm not knocking these women. I'm actually very appreciative of the efforts of many celebrities who have come forward to talk about their postpartum depression. However, we can have some empathy with these. However, the other time we hear about maternal mental health is when there's horrible headlines, and we can all gasp in collective horror at what a bad person this mother must have been. But there's not much in between. I also want to point out that the bias actually extends to science, and that's part of why I wanted to bring this up to this room, because it's really important for everyone to understand. We recently reviewed in our journal club this paper that was published in Pediatrics, which is the major clinical journal for pediatrics, entitled Drinking or Smoking While Breastfeeding and Later Cognition in Children, where they had come to the conclusion that exposing infants to alcohol through breast milk may cause dose-dependent reductions in their cognitive abilities. So, you read that and you sort of nod and say, well, we know alcohol is bad in pregnancy, it's probably bad in breastfeeding, that makes sense. Except when you read the paper, it actually doesn't say that at all. In fact, what it says is exactly the opposite of what its conclusions are. There was one out of the 3 measures they did at 3 different time points, one measure at one time point showed a statistically significant difference. 1 out of 7. And no level of alcohol use, self-reported alcohol use in pregnancy was associated with any cognitive problems in children. So talk about bearing the lead. So you can't read the abstract. And I'm myself biased, I review this literature all the time. But I think that in maternal mental health, this is a particular risk. And why is it a risk? It's not just that, I don't mean to put this up there to say, oh, it's okay, tell your patients they can breastfeed and drink, but because these studies have consequences. As our colleagues Paul Applebaum pointed out, along with the former fellow Cara Angelata, women are getting charged and put in prison for using substances in pregnancy. 3 states have explicitly criminalized as fetal abuse, use of illicit substances and alcohol in pregnancy. So this criminalization and this level of punitive action actually is associated with less access to the needed treatment for women and their families. So it's important. And I'll take a little bit of a side note here to talk about some of the limitations of the data in maternal mental health and perinatal mental health. We don't have randomized controlled trials of psychotropic medications in pregnancy. As I explained to my patients when I'm talking to them about this topic, I say we don't really just give fluoxetine to an otherwise healthy woman and say, hey, take this, let's see what happens to your baby. So we're reliant on prospective and retrospective data. However, these data sets most often have inadequate information on confounders. Not surprisingly, women who take SSRIs or other medications in pregnancy have higher rates of psychiatric illness. Substance use, they have much higher rates of substance use, poor prenatal care, and differences in body mass index, nutrition, socioeconomic status. Many of the confounders that are associated with maternal depression and other psychiatric illness are clustered in women who are on these medications in pregnancy. There's also issues around recall bias, confirmation of exposures, and the relevance of some animal studies. So confounding by indication should really be on your radar as you're looking at any of these studies. And really looking, particularly as we have more and more of the sort of big data studies, these huge databases that have a lot of power to find very statistically significant findings that may or may not be meaningful or may not be causal. And this has implications for me as a clinician as I'm looking through the literature. Every time a new study, there's a publication bias in the press, of course. They love to publish anything negative about psychiatry and psychiatric medications in pregnancy. So I get frantic phone calls every time something new comes out. So why is the perinatal period a high-risk time for psychiatric illness? Why? So that we know that it's stressful. It's really important to understand it. It's also a high-risk time. Why is this a stress test? So I'll talk a little bit about etiology and risk factors and morbidity in the course of illness. This was a study from the 1970s in Edinburgh when Kendall and al. Looked at primiparous women and rates of psychiatric hospitalization compared to their delivery date. And what they found was that compared to the 2 years prior, women had a 4-fold increased risk of first-time psychiatric hospitalization after parturition, and it never quite returned back to baseline. Now, that may just be an effect of time, although those of you with children may have some other thoughts about why that may be. This is a much more recent study that looks at first-time hospitalization in women, or first-time psychotic episodes in women, and compared to time since delivery as well. With the dashed line is all maternal psychoses, and the solid line is psychosis in mothers without any previous psychiatric history. Once again, you have the same finding of this 3 to 4-fold increased risk in the postpartum period. So this is a high-risk time. And why is that? Why is the perinatal period a time of vulnerability? So we think about biologic factors, hormonal changes, immune modulation, sleep deprivation is an important one, stress, as Dr. Lieberman was talking about, and the psychological transitions, the profound changes in the role as a mother and changing family dynamics. I always think about this when I had my first child. It was long labor, and the baby, my daughter was being looked at, weighed, and measured, et cetera, and I was exhausted, sitting there on the delivery room table, but happy. And then I hear a baby cry, and my first thought is like, somebody better take care of that baby. And then it was like, oh, that's me. And that was like the moment of like, okay, this is a transition. This is a moment of transition. It became very concrete at that moment. So this is a pretty cartoonish graph of what happens to hormones in pregnancy. So peak progesterone levels by the 3rd trimester reach about 500 nanomolar, and estrogen levels about 400 nanomolar. As a comparison, in the peak of the menstrual cycle, in the peak part of the luteal phase, the progesterone levels reach probably about 20 to 30 nanomolar. So this is a huge increase in estrogen and progesterone. And then at delivery, the placenta is producing all of the estrogen and progesterone at that point. At delivery, within 48 hours, the levels go down to postmenopausal levels. So there's a huge hormonal trigger that happens at that moment. And in fact, it's why we think that, part of why we think that 80 to 90% of women have what we call the baby blues, which is really a benign dysregulation in affect and sleep and irritability that shouldn't last more than 2 weeks, but often gets confused with postpartum depression. There's also other evidence to suggest that there's a hormone link. So women with a history of postpartum depression will respond much more dramatically to the add back and withdrawal of estrogen and progesterones. Women were treated with, this is a David Rubinow's group at UNC, women were treated with Lupron to suppress their hormones. They had 4 weeks of add back estrogen progesterone and then 4 weeks of withdrawal. And this shows looking at depressive symptoms. And this is a comparison group with no history of depression. So there's a significant increase in risk. There's also an interesting link now. So there's a new medication just poised to be on the market called brexanolone, which is an allopregnanolone derivative. So allopregnanolone is a progesterone derivative that works on the GABA-A receptor. It's an allosteric modulator of the GABA-A receptor. There's been really interesting data out of UNC and other places suggesting that this is actually a unique treatment for women with severe postpartum depression. This is given as an infusion, and the phase 3 data actually looks quite nice in terms of decrease in symptoms. For this group was the less severely depressed group, but in the severe depression group, there's a very clear rapid response to the infusion. So this actually is quite exciting for those of us in the field. It's the first specific medication potentially poised to be on the market for postpartum depression. There are others no doubt being developed. Actually, I think if Jonathan Stewart is here, he is involved in recruiting for one. But we think that there is probably a hormonal component to this. But of course, hormones or even the biological changes aren't the entire story. There are other risk factors. So the number one risk factor is a prior history of psychiatric illness. Anxiety in pregnancy is a real marker for potential risk. Stressful life events in the perinatal period, low socioeconomic status, poor partner support, medical comorbidity, low social support, a history of trauma. And I will say, in the Medicaid clinic, about 90% of the women who present in the Medicaid, our women's team in the Medicaid clinic have some history of trauma, usually many layers of trauma over time. But even in the sort of more the private patients that I see, that rate of history of trauma, I'd say 60-70% of the women that I see have had some history of trauma. I think there's a lot of reasons I think that the perinatal period can be particularly raise a lot of issues around women with particularly sexual trauma and physical abuse. Intimate partner violence, as we noted, unintended pregnancy, obstetric complications, and gender mismatch. Actually, in the world literature, another risk factor is stress with conflict with in-laws. So what are the risks of perinatal mental illness? What are the possible consequences beyond what we've talked about in terms of the fetal origins of health and disease, where stress in pregnancy is a toxic exposure that can have implications for the child's brain development and the child's development going forward? There are also obstetric complications that are associated with perinatal mental illness, as well as complications for the child. But I do want to point out that we often in this discussion, we forget to talk about suffering, that our patients with psychiatric illness suffer terribly. I tell this story a lot, so forgive me those of you who heard me say it before. But there was one time I was treating the woman who, in her second pregnancy, who was going through a horrible depression. Once she recovered, she told me, in my first pregnancy, I was in a car accident and had a broken leg, and I needed surgery. No one in that, I was pregnant and I needed the surgery, it was terrible, but no one ever said to me, well, I'm sorry, we can't give you any pain medication because you're pregnant and it might hurt the child. It was like, of course, we have to treat your pain, don't worry. But she said, I would take the broken leg and the surgery over that depression any day of the week. So it's really important that we think about the level of suffering of our patients. Women with psychiatric illness or depression or anxiety or any psychiatric illness are at risk for poor self-care in pregnancy, poor sense of efficacy in mothering, an elevated risk of abuse and violence. There are much higher rates of smoking and other substance use and abuse, higher rates of suicide, lower rates of breastfeeding, postpartum, and the risk of postpartum illness and psychosis. There are adverse effects on family systems and supports for being ill during pregnancy and the postpartum. Adverse effects on the cognitive and emotional development of children, poor attachment, undesirable safety habits and exposure. There are higher rates of cesarean delivery in women with psychiatric illness, as well as preterm birth and low birth weight, even the absence of medication treatment. There's rare but real risk of infanticide, as well as neglect and abuse. So I'm going to shift gears and talk a little bit about what we know about some of the major psychiatric illnesses and their course during pregnancy. So depression, the DSM-5 defines perinatal depression as major depression with peripartum onset. It's a depressive episode, so our usual depressive symptoms, that begins during pregnancy or within 4 weeks after birth. So that was a big shift from DSM-4 to DSM-5, recognizing that depression can start in pregnancy. However, most clinicians and researchers define the postpartum period or perinatal depression as extending up to within a year after giving birth, sometimes longer depending on if the woman is still breastfeeding. In terms of prevalence, about 12% of pregnant women will experience depressive symptoms at some point during pregnancy, and about 20% of women during the first year of giving birth. As a comparison, preeclampsia affects, both preeclampsia and gestational hypertension affect about 5% of patients, and they're screened for and dealt with at every OB visit.
Is the 12% part of the 20%?
20% is the first year after giving birth. So, and this includes major and minor depression.
Is that to say that the total number of peripartum?
Yes. So it may actually start in pregnancy, but it will continue postpartum. Yeah. 2/3 of perinatal depression actually begins before birth. A quarter of women come into pregnancy with some history of depression. A third may start to have depressive symptoms during the pregnancy, and 40% have the onset in the postpartum period. I won't go through the major depressive symptoms. Hopefully, everyone here recognizes those. But I just will point out that that anxiety is really the norm with perinatal depression. There's so few patients who have presented with pure depression without comorbid anxiety that, it's a joke with my fellows. It's like, okay, how many generalized anxiety patients with intermittent depression have you seen? Let's get you some other cases, because this is who presents with psychiatric illness. It's not depression in the absence of anxiety. Comorbidity is really the rule. Especially in the postpartum period, you will often see obsessive ego-dystonic thoughts, often of harm coming to or harming the baby. And in fact, those obsessive thoughts can actually occur in the absence of psychiatric illness. There's actually a rate of those thoughts happening in women without psychiatric illness. It seems to just be triggered. There can be a lot of checking behaviors around the baby. And a key marker of this, the one question I always ask is she sleeping even when the baby is if she's not sleeping, even when the baby is sleeping, that's a marker that there might be something else wrong going on.
Postpartum psychosis.
I'm getting to that, but yeah, so it's important to distinguish these obsessive ego-dystonic thoughts of harm coming to or harming the baby from the thoughts that might occur in a woman with postpartum psychosis. So in general, these women who presenting with depression and anxiety in the postpartum period with these horrific thoughts are not at risk of harming their children. In fact, they're horrified by the thoughts, they're frightened by them, they're shamed. It's devastating to experience them, and they sometimes don't even want to touch the baby because they're so afraid of these thoughts occurring. That is distinguished from women with postpartum psychosis, which is a much more severe it's a psychiatric emergency. It's much more severe and has a relatively high rate of both suicide and infanticide if left untreated. Women with bipolar disorder have the highest rates for postpartum psychosis. The baseline rate in the population is 1 to 2 per 1,000 live births. Women with bipolar disorder have significantly higher risk. About 80% of women who present with a postpartum psychosis have or will have a diagnosis of a bipolar spectrum disorder. So bipolar disorder or schizoaffective disorder are most common. About 10% actually have a diagnosis of schizophrenia in contrast. They can express paranoid, grandiose, or bizarre delusions. They have mood swings, and grossly disorganized behavior. There's a lot of confusion, and importantly, there's waxing and waning. So it looks delirium-like. So a woman may actually be lucid for several hours at a time, and then be completely psychotic several hours later. So this is a psychiatric emergency, and so it's very important when you see a woman with thoughts about harming the baby to distinguish, is she psychotic or not? That's one of the critical pieces. In bipolar disorder, we know that the course of bipolar disorder in pregnancy. So this was a study from Adele Viguera and Lee Cohen in 2000, where they looked at women who had been with bipolar disorder who had been stable on lithium for the prior year and followed them out for 64 weeks. And they compared them to women who, so half of the women stopped lithium because they got pregnant or were going to get pregnant. Half of them stopped lithium for other reasons but were not pregnant. And they followed them for a year. In the first 9 months of the study, which correspond to the 9 months of pregnancy or a similar 9 months for the other women observed, the survival curve was about 50%. So about half of women over those 9 months had a relapse to some mood disorder over the course of that time. And the curves were overlapped between the pregnant women and non-pregnant women. However, in the postpartum period, weeks 41 to 64, the women who were now postpartum had a 3 to 4 times higher rate of psychiatric illness. Even the women who had successfully navigated through pregnancy off of medication had a 4-fold increased risk for psychiatric illness in the postpartum period. So in bipolar disorder, the postpartum period is a particularly dangerous time. And that should be talked about that way with your patients. In terms of other serious mental illnesses, it always seems like a surprise to know when people learn that most women with schizophrenia and bipolar disorder have children. They are more likely to be unplanned. But in one qualitative study, women with schizophrenia were just as likely to describe motherhood as central to their existence. Fertility in SMI women is lower than the general population, but we think that the trends are actually increasing, and that may actually have something to do with the change in prescribing of medications. They're on fewer medications that cause elevated prolactin over time, and there may be other reasons as well. So SMI women are less likely to access prenatal care or enter late to care. They have higher rates of unplanned or unwanted pregnancies, higher rates of abortion. They're more likely to be victims of violence. They're more likely to have children in foster care. And there's higher rates of comorbid substance use. Okay, so let's shift gears. And I'll ask the question, how can we use this knowledge to make informed treatment decisions with our patients? So I like to think about this as, we think about things as like, well, I can treat the mom or the baby, that their mom and baby are in opposition. And I like this cartoon. It says, did you know it's not your health that matters, it's that of the womb that could bear an unborn child? Versus this perspective, which says, I don't care if it's a boy or a girl, just as long as I'm healthy. But really, what we should be talking about is what Laura Miller in Chicago calls a system of relational ethics. That, of course, the well-being of the fetus and the child are intertwined with the well-being of the mom and the family system. And so whenever you're talking with your patients about childbearing, you're already, even if it's theoretical, you're already dealing with the family system. And you have to understand that the well-being, mom's psychiatric and psychological well-being are really at the core of the well-being for her family. And so whatever we can do to increase the supports will help the baby as well.
Betsy?
Yep.
Can I try and clarify something? You are talking about what we can do with our patients, meaning, I guess you're referring to mental health care providers?
Yeah.
But what proportion of the women who experience peripartum psychiatric conditions have pre-existing illness that might lead them to be engaged in treatment as opposed to something occurring de novo?
So actually, the data on that isn't great. But if you look at the data about depression in pregnancy, about a quarter of women will have had pre-existing depression before. We just know a lot more about depression than other psychiatric illnesses. It's much more studied. So we do know that that's that a lot of women have pre-existing psychiatric illness. I'm actually working with Kathy Wisner and Molly Finnerty to try to look at this question about the rates of pregnancy in psychiatric clinics. But there's really not a lot of data about that. However, we do know that most women with severe psychiatric illness actually do have children. And while women do tend to present with the first episode in the peripartum period, it's a high-risk time for first episode, there are still also women who present long before, and we see a lot of them in our clinic.
Yeah, but if it's 25%, that means the majority are occurring de novo during during pregnancy or after pregnancy. And
Well, let me rephrase that. 25% had depressive symptoms prior to the pregnancy, whether or not they'd had a recurring illness before, and that's just.
I guess my point is that all that you're saying about what needs to be done needs to be extended to either other primary care specialties.
Absolutely. Absolutely. To OB, family medicine, primary care, and I think even beyond, this understanding really needs to be beyond the healthcare system. We sit within our walls in the healthcare system, and there's a lot of psychological distress and psychiatric illness that exists way outside the bounds of our system. And so how can we actually think about real prevention? Because as we know from genetics and epigenetic studies, even identical twins with schizophrenia have different rates of illness, right? It's about 50% concordance. So there are these many other risk factors that have to happen in order to express psychiatric illness. And I think that really focusing on perinatal well-being is one way to really think about prevention. And yes, to a group of psychiatrists who are treating ill patients, I am talking about secondary prevention with our patients who are already ill. But absolutely, from a public health perspective, I think mental health needs to be front and center in the discussion about how to prevent psychiatric illness from occurring.
Just one more comment. It's been a while since I had children, but I remember going through the Lamaze classes, and I don't recall there being any discussion about, the emotional or psychological dimensions of pregnancy or preparing for childbirth.
That actually has changed over time. That I have to say, I think that obstetricians and family medicine doctors and midwives have actually really gotten the message that mental health is important. They may not know what to do about it or have the resources, even if they identify someone with a psychiatric illnesses, for where to send them or how to deal with it. But they're much more clued in on the importance of mental health. I mean, we experience that all the time, especially in this system. Our OBs are really happy when their patients are in treatment. They really feel like they feel pretty good about that. So I think there has been a huge dramatic shift in that perspective. In fact, in some ways, as someone who talks about risks and benefits of medications all the time, it actually can go a little bit too far, where people are a little bit too blasé about, it's just stay on your medication, it's fine, without really thinking about it. And that's what I spend my time doing, is really thinking about it. Do you need to be on 3 medications or 2 of these to deal with the side effects of the one? So let's be thoughtful about this. Or did you start on that paroxetine when you had a couple of panic attacks in college and you've never had CBT? Let's maybe try some CBT and see if we can get you off the medication. So I think that there is a balance, and unfortunately, in the context of a 7-minute face-to-face time with an obstetrician, there's not a lot of time for nuance. And so people really want the clear question, like, are medications safe in pregnancy? Well, the answer is, they're safer than not being on medications if this is what's really keeping you well. But there's not one blanket answer. In fact, that's the next question. A lot of patients come to us. Is it safe to take my medications in pregnancy? Or with the question, what medications are safe to take in pregnancy? And the answer is complicated. And as I was referring to, I do see some patients who probably could remain well off medications, and in whom I'd say, you know what, you really should try to get off, because why expose this child to risk? And there are risks to everything. There are risks. There are risks to breathing. There are risks to drinking water. And there are significant risks to our medications. And then there's another group of women who it's very clear cut. They get suicidal every time they try to come off, and it's very clear they need to stay on. Most patients are in the middle ground, and in fact, most patients, it's much more complicated. There's a lot of different factors that go into decision-making about whether to be on medications in pregnancy. Like people, you want to do monotherapy, but one medication never worked for this patient. For a different person who has one child with autism, they're really fearful of doing anything that might raise the risk of autistic spectrum disorders. They're listening to their OB who says no, or their psychiatrist who says no medications, despite what you're saying. They're over 40 and there's pressure to conceive. There's a lot of different possible reasons that people have in this is a very complex decision. So we think about it as a risk analysis. We're not dealing with, it's not just risk-benefit. And we frame it this way, and this was actually, Meg Spinelli is the one who taught me to draw a line on a piece of paper and sit down with my patients and talk about the risks of untreated illness and the risks we know of at this time of medications. And this is how I still talk to my patients about this. And when we're talking about risks of untreated or undertreated illness, we have to know what's there from the literature. We have to know what we know about the course of depression, anxiety, bipolar disorder in pregnancy. What treatments are indicated? A lot of people, for example, my patients who've had panic attacks but have never tried CBT. Why don't we try some CBT and see if we can get you on less medication? We also need to know about what are the risks of untreated illness in terms of exposures on the child and obstetric risk. And then what's specific to the patient? How ill do they get? What happens to their functioning and their ability to take care of themselves and their potential ability to take care of a child? How many recurrences have they had? What happens when they've come off medications? What's their self-care like? What's the effect on their family system when they're ill? Does it cause cracks in the family system that can really themselves affect the existing children or future children? What's the risk of suicide, and what's her treatment history? And then thinking about risks of treatment, especially somatic treatments. In the first trimester, we worry about teratogenicity and miscarriage. Later on, we worry more about effects on birth weight and prematurity and neonatal outcomes, including neonatal adaptation syndrome and persistent pulmonary hypertension. And then we worry about long-term neurodevelopmental aspects. And in terms of antidepressants, much of this has been pretty well characterized, and this is what's still being characterized by many people in our department as well, and effects on lactation. Just a reminder for everyone to really think about non-pharmacologic treatments, and especially psychotherapy. I see a lot of patients who are in long-term supportive psychotherapy and have a wonderful relationship with their therapist. But you also have to think about psychotherapy, as Dr. Kapanis can tell us, as a specific modality that can be specifically helpful for people, and maybe they could use some additional support. ECT, TMS is being studied in pregnancy. Bright light therapy is very underutilized. The story on omega-3s is still is not that great, but the risks are not so great, and there's some evidence for it in pregnancy. Anything that increases support is perinatal depression is very isolating. Anything that increases support is helpful. Acupuncture, yoga, exercise. Do I know why acupuncture works for some people? Nope. Do I care? Not particularly. Sleep regulation, and in the postpartum, I think it's really important to focus on both practical and emotional supports. So these are my treatment principles in perinatal psychiatry, my top 10 list. The first is don't panic. I see a lot of anxiety-based prescribing and a lot of anxiety-based non-prescribing. So someone who's been stable on aripiprazole, for example, for their bipolar disorder, who gets pregnant and then the psychiatrist panics and switches her during her pregnancy to haloperidol, even though she's never tried it. We don't know if it's going to keep her stable, and she might have side effects to it. Okay, I would encourage you to stop, take a deep breath, and think about what you're doing in terms of taking all of what we've talked about in terms of the importance of keeping and how difficult it is to keep our patients well into the decision-making about what you're doing with medication. So the first rule is really to know what you're treating. I think anyone who's been a clinician long enough has patients who don't fit neatly into diagnostic categories or whose your diagnosis has probably shifted over time. I see many patients with a diagnosis of bipolar disorder who I really think probably have some history of trauma, and that's being expressed in these dysregulated ways, and they may have looked bipolar as an adolescent when they were also abusing cocaine and not telling anyone. So it is important to know what you're treating, because how do you know what treatments are actually indicated if you don't actually take a careful history? And the perinatal period is a good time to revisit your diagnosis in your patients. Second, there are no risk-free decisions. We have to take a radical acceptance approach to this and recognize that when there's illness, including psychiatric illness, there's risk. There's risk to treating, and there's risk to not treating. And we really have to help our patients balance these risks. We want to avoid polypharmacy where possible and avoid switching medications if we can. There's not one algorithm. You have to do the risk analysis for each patient. The best medication is usually the one that works for the patient and the one that has worked for the patient. There are some exceptions, most notably valproate, which we really avoid in all trimesters of pregnancy, as it's neurotoxic. We want to use the lowest effective dose of medication with a emphasis on effective. I can't tell you, it's part of the bread and butter, so I don't want to tell you this deep secret, but when a patient's usual dose of escitalopram is 20 milligrams, but she gets pregnant and her psychiatrist tells her to lower it to 10 milligrams, and then she gets depressed and comes to me for a consultation, my brilliant intervention is going to be, let's go up to the dose that has worked for you. So, women and providers really want to minimize exposures, which is understandable. But if you do that, then you're exposing her both to a medication, the 10 milligrams of the escitalopram, and to the untreated depression. And there's no guarantee that the same level was going to work in the same way the next time. Maximize non-medication therapeutic options. Look up what's indicated, what she's done, what she's willing to do. This is a moment that people who have not been willing to engage in treatment modalities may have more motivation to do so. You want to involve the family and partner when possible. You really need to consider a family system and what her supports are. You want to stay up to date on the literature, but with knowledge of the confounders and the context of each study. And then communication and education with the patient, the supports, and all treatment providers. Finally, I want to end on this idea that the perinatal period is a time of high risk, but it's also a moment of opportunity. People are really motivated for positive change. We've talked about all the horrible things that can happen, from death to a lot of morbidity in the perinatal period because it is so stressful. But it's also a wonderful period where people can really take this motivation to make changes for their children that they really have a hard time to doing for themselves. We all know smoking is bad, for example. And nationwide, about 20% of women smoke. That number goes down significantly in pregnancy. It goes down to about 4 or 5% in pregnancy. So women can quit smoking in pregnancy, for example, because they're motivated to do so in a different way. However, our patients with depression have higher rates of smoking, for example, at baseline, and a harder time quitting. The rates don't go down much in women who smoke during pregnancy, but we can maybe help them if we treat their depression, if we really work with them, we can help them make these positive changes. Clinicians are educators. We're educators for each other, and we're educators for our patient. We can be proactive in our model of maintaining psychological well-being and pay attention to intergenerational effects. So in terms of my wish list, what else can we do? The first is really ask about family planning. You should be asking all of your patients, men and women, about family planning. And there's a good question is, are you planning, or do you wish to become a parent in the next year? Or do you wish to become pregnant in the next year? That's a good question to ask. Ask about safety. Work with our non-mental health colleagues to improve screening and access in the puerperum. Ensure that every psychiatrist has a basic understanding of the risks of the perinatal period and its treatment. Improve access to specialized consultation when appropriate. And improve access to psychotherapy. For researchers, my wish list is further understanding of the consequences of perinatal distress and its underlying mechanisms. Getting some specificity about which children may be at most at risk from both the illness and its treatment. The development of novel treatments, treatments that minimize exposure, understanding the role of sex hormones and immune function, and utilizing big data responsibly as we learn more about maternal mental health. From a systems perspective, we need to improve access to care. We have to expand services beyond the silo of healthcare. That's one thing I've learned from our domestic violence work. When you actually put providers into settings beyond the healthcare system, people who would never set foot in a clinic will actually come and see you and actually can really benefit from what we have to offer. We want to pay attention to maternal health equity and advocate for non-punitive approaches to substances, mental health, and child welfare. So just some thank yous to our group at the Women's Program and the Domestic Violence Initiative. And then I'd like to end on this picture because it's not all bad. Thanks very much.
Well, Betsy, thank you for a great talk. And we hear a lot of topics discussed, but there's probably few that have relevance to each and every one of us more than this. Let me start off the discussion by asking a question. So in life there's sort of life cycle milestones. Birth, which are traumatic of various ways, but they're naturally occurring traumas, so you can't call them pathologic. Mm-hmm. So there's birth. There might be your bar mitzvah or your catechism or First communion, however psychologically demanding that is, but then there's marriage, there's childbirth, and there's death. But none of them is so commonly associated with the potential for some psychopathologic sequela as pregnancy is. Do you have any thoughts about why that is?
I think it's important to think historically about pregnancy. We're talking about how horrible it is to have a risk of 18 maternal deaths per 100,000 live births. But 100 years ago, it was actually celebrated when they finally reached, actually it was 1950, there was an article where they celebrated finally reaching what they thought was the irreducible marker of 100 deaths per 100,000 live births. Childbearing has been a high-risk time from throughout evolution. And in fact, in some of the developing countries, the rates of maternal mortality are still about 400 per 100,000. And that's significantly lower. There's a lot of, I think it's the combination, it's the whole biopsychosocial model. It's physiologically very stressful. It's psychologically very stressful. I mean, we didn't touch that much on trauma, but there is trauma, there's real trauma that happens. There are also attachment patterns and relationship patterns that get thrown off in this period of time, which can then lead to traumatic consequences, to losses of relationships, to misunderstandings, to being abandoned at this moment of need. And all of those dynamics, I think of this time, I joke that this period of time is dynamic with a capital D and a lowercase d. And then there's the social change. What happens when when all of your relationships change at once and your identity in society goes from a person to a mother or to a parent? So I think really it is the crux of the biopsychosocial model all coming down into this one period of time.
So childbirth is basically fraught with risk, and psychological consequences are one form of risk.
Yeah.
Jonathan.
Hi, Betsy. Thank you so much for giving that really, really wonderful talk. It was super informative and interesting. One question. Is that okay?
Who's doing the? Oh, you got it. Okay.
Yeah.
Good.
One question that I had is on postpartum blues,
Yes.
and I don't have any of the clinical experience to really have an informed opinion about this, but when I hear people talk about it and it as a normal and as you said, a benign experience, it worries me a bit that that it may be masking true postpartum depression or even subclinical depression that still needs interventions. And I guess I'm just curious your thoughts on that.
Yes. So absolutely. I mean, sort of normal postpartum blues or transition, often it's sort of like what I think about it is the sort of that crying at the Hallmark commercial kind of feeling, where you can be happy one minute and there's a lot of lability. So there's a lot of movement in the mood. There can be irritability, there can be some decreased sleep. You've just gone through this huge physiologic experience, as well as all the psychological stressors. So there can be these individual symptoms there that overlap with depression. But there are some symptoms that should not be there. I mean, suicidal ideation is never normal at any time, even one day after birth. Persistent low mood or persistent numbness or inability to bond with the child or persistent irritability, sort of the stuckness of a mood, is an indicator that there may be something more than just a normal transitioning postpartum blues. So we think about it as sort of benign and self-limited, but absolutely it can, and oftentimes women's symptoms get dismissed as just the blues, when in fact they're clearly more significant than that, and are not going to necessarily resolve on their own in 2 weeks. Myrna, I'm sorry.
Myrna. Do you have a mic? Oh, did you have were you going to ask
Thank you very much. It was a pleasure to get the whole view because we only get it in little parts, so it was very informative. I want to just say two things. First of all, because there's a lot of women in this audience, a lot of residents who may not have had children, you have to, in this kind of a situation, emphasize all the bad things because you have to treat them. But for most women, having a child is a great experience. and doesn't ruin their life, but gives them extra status. So, and especially in some cultures, which we have also found in our studies where we have these strange findings that around this hospital in the group that of women that we have studied in our remission studies, that and we did a study with Canada, that our single parent women who usually do very badly, did actually very well. And of course, if you consider the population around the clinic, they were primarily Hispanic women who live in large groups, and there's always somebody around to help take care of the child. So I just want to emphasize the good things.
Absolutely. That's why I put that up there, just to remind people.
The second thing is the U.S. Preventive Task Force has something circulating now, I'm sure you've probably contributed to it. And they're recommending, and I think you have to treat depression very vigorously. And it's a terrible dilemma for a clinician if a woman has been on medication to take her off it. I would not like to be the clinician in that situation. However, there's a lot of the depressions that are sort of mild or prodromal related to the transition in the situation. And the U.S. Preventive Task Force now, which I think will publish this in February, is recommending psychotherapy, evidence-based psychotherapy. How in the world are we in the United States going to provide that? Most of the women or men who treat pregnant obstetricians and gynecologists are going to be in a dilemma because it's just not going to happen. And that's very different in a lot of other countries.
Yeah, absolutely. I 100% agree with you, Myrna. And it's part of what I was thinking of when way back at the beginning of the talk, I talked about the cliff, right? That actually one of the structural issues affecting maternal health is our healthcare system and the way it's structured and the payer system. That, women here, they don't have access to psychotherapy. Even if you're sitting even in the clinic, so in the Medicaid clinic where I spend a day a week supervising and treating patients, I'm sitting there and patients don't show up. And that's not because they don't care. It's not because they don't want to. But they have other lives and they have other priorities and they have to overcome a huge amount of stigma and trauma and other factors to get in to see me in the clinic. And I'm there waiting for them, let alone the fact that there's not access in many places and people not trained in what to do. So, I think that there are some models that may work. I mean, we've talked a little bit about this. Some like telephone-based therapies, telehealth actually can probably get their training more lay people in some of the techniques of assessment, and then having a system that actually better risk stratifies so that women who really need the specialized services for trained psychotherapists, for example, are getting that, whereas women who might do better with some social support can get that. But I agree with you, Myrna, 100%. We should all be advocating for more access for our patients so that I don't have to prescribe. I don't like to prescribe in pregnancy. And I think that there are many of my patients who, if they had better access, I wouldn't have to.
I want to make two comments, and then we're going to go here, and then to Dr. Wharton. First comment is, so, the term maybe, what you use, blues or prodromal, maybe it should be subclinical. The subclinical mood, disturbance. Also, Myrna, some number of years ago, you wrote a paper about the death or the absence or the fallacy of involutional melancholia. Am I remembering that correctly?
Yeah.
And that basically was trying to debunk the notion that there was a menopausal associated depression that women were susceptible to, which presumably was hormonally related. Did that debunk the prevailing thinking, and is that still what you would say currently? I'm only raising it just because we're talking here about an event, a psychopathologic event that's associated with sensibly hormonal change, and now with the advent of brexanolone, which kind of provides another line of evidence in support of it.
Well, much of what we publish doesn't change patterns, but I think it's very well established now that and those are not just our studies, but about 3 epidemiologic studies and lots of other studies, that the peak onsets for depression, especially in women, is between the ages of 15 and 30, and that after the age of 45 or 50, first onsets go down. In fact, if somebody has their first onset around 55 or 60, you begin to think there's some other problem that is not related to depression. That's the Cornell group has shown that. However, that doesn't mean that women who've had their onset at 15 don't have recurrences during menopause. But the onset of depression in the menopausal period definitely goes down. It's much, much lower then. And the onset occurs in adolescence and, of course, right after childbirth. There is a slight peak in the perimenopausal period in women who've never had a depression. We just see a little peak, and others have shown that.
Mm-hmm. There's actually, just as Myrna said, like postmenopausally, rates of new onset depression go down and are pretty much equal to men and postmenopausally. There is the data looking at hormones and the impact of hormones on mood disorder suggests that there's a subset of women who have what is being called hormone-sensitive mood disorders. So, for example, women who have premenstrual dysphoria symptoms are more likely to have depression, perinatal depression. They're also more likely to get depressed during menopause. There's also some interesting studies. There was a study out of Harvard a few years ago where they looked at about 200 women between the ages of 35 and 45 and followed them for 8 years. These are women with no history of prior depression. And they followed them for 8 years, looked at hormone levels, and looked at symptoms, clinical symptoms. The women who entered perimenopause, not menopause, but perimenopause during that time, were 4 times more likely to have clinically significant depressive symptoms. So that perimenopausal transition, where the hormones are changing and the biology is changing, along with some other life factors going on, is probably that secondary peak that you talked about in terms of new onset diagnoses. Interestingly, too, onset of bipolar disorder in women is a bimodal peak as well, and that probably could represent childbearing. It could also represent perimenopause.
Thank you, Dr. Fitelson. Very thought-provoking talk. I'm motivated to ask a pair of related questions by experiences that I think several of the trainees have had with patients who have been psychiatrically hospitalized during pregnancy, and sometimes for the bulk of their pregnancy, even to the point of, disposition plan is discharge after delivery, which raises a whole host of questions. But the 2 questions that I basically had in mind were, you showed that beautiful graph, albeit somewhat, kind of dated, I guess, from the 70s, of the risk of psychiatric hospitalization immediately in the postpartum period. I wonder, are you aware of any evidence of there being a different profile of risk for hospitalization for women who have previously, like in a later pregnancy, who've previously had hospitalizations or serious mental illness in the peripartum period? Does that risk profile look different? And my follow-up question would be, are there any resources that you are aware of that you utilize beyond the kind of resources that might be available for any patient who's in crisis that you would mobilize to potentially prevent hospitalization for patients at risk?
So regarding your first question, there's not great data on treated mental illness and risk of recurrence in the postpartum period. There's some data. So Adele Viguera's group, I didn't show this slide, but Adele Viguera's group also did a follow-up study to the lithium study where they looked at women. It was a naturalistic study following women who were pregnant and either continued or discontinued their mood stabilizing medication during pregnancy. What they found, probably not surprisingly, was that the women who continued their medication had far lower rates of relapse during pregnancy. But they still had about 25% of women still did relapse. It's not clear if that's because of undertreatment or just the factors involved in the perinatal period kind of breaking through treatment. So treatment does reduce the risk of relapse. It doesn't bring it down to 0, though, but I can't give you a quantifiable number. In terms of preventing hospitalization in women with SMI, so when I'm consulting with a patient who's pregnant with bipolar disorder, for example, I'm really, even before she's pregnant, I'm already talking about the postpartum period and looking at her supports. Because a lot of the women you're talking about, and I know I've been involved in many of those cases, they're in the hospital because, yes, because of their illness, but really because there's no support there. All they have is a very shaky safety net that has already failed them in many ways. So whatever opportunities you can put in place in advance, with whether there's family, the friends, whatever social services are available that you can engage the patient in engaging, can be helpful. Unfortunately, our system is such that, again, looking at this cliff, it brings it to mind that there's a lot of mistrust of our social service system for some good reason. And also, for a first-time pregnant women, there are some resources like the Nurse Family Partnership, for example, and Healthy Families, which will do home visiting, which are wonderful programs. For our patients with really serious mental illness, that's probably not enough, but it certainly is helpful. My fantasy is that we could have a maternal mobile crisis team, or a maternal ACT team, actually, essentially. And actually, I talked to Hella Thorning about this at one point. For some of these women who have really serious mental illness, but who could actually parent with the right supports, levels of support. So I'm not sure if I've answered your question, but whatever resources you can gather.
That was very helpful. Thank you.
ACT is a sort of community treatment. In terms of Joseph's question about hospitalization, so with brexanolone, given it's a 60-hour infusion, can you do it as an outpatient?
Not right now. It's only an inpatient infusion, I believe.
You'd have to hospitalize them just for administration.
I think so. You know what? I don't know what the ultimate FDA indication is going to be. It's still poised. I think it's been deferred. It was going to be in December. I think it's been deferred till March now.
Well, it's been approved. Maybe the labeling language may not be worked out, but the FDA did approve it.
The committee approved it. It hasn't gotten the.
Oh, okay.
Yeah.
You're right. Yes, sir.
Yes, I just wanted to,
Oh, wait. Ralph, hang on. Age before, well, however it goes. This gentleman was next. We're going to get to you, though, right after.
Great talk, thank you. And I really appreciated your 10-point summary of medications and really summarized it well. I guess my one question is, that's really a question in my head, is lithium. And very specifically, so I have a patient who's about 32, one manic episode, no substance use, hospitalized for mania, very stable on lithium, and is now thinking about getting pregnant in the next year. What's the story on lithium in the first trimester?
So it's tricky. So we all learned boards question, lithium, Epstein's anomaly, right? It's on your boards. That's the right answer on the boards. Lithium does increase the risk of cardiac anomalies, including Epstein's anomaly, significantly. But the numbers are not what when they were estimated to be at first. I thought, based on sort of case reports with no denominator, the estimated risk of Epstein's anomaly was something like 1 in 100. The baseline risk is about 1 in 20,000 to 1 in 30,000. Lee Cohen did a review looking at more recent data about the risk of lithium in pregnancy, and the highest level of risk, the risk of Epstein's anomaly goes up to about 1 in 2,000. So a significantly higher risk, but still quite a low risk of Epstein's anomaly specifically. There are other risks of lithium in pregnancy. It's the salt. It affects fluid balances. Polyhydramnios is an issue. Fetal thyroid dysregulation, cardiac arrhythmias in the fetus. There's perinatal issues with lithium. However, one benefit of lithium is that it does not appear to be neurotoxic. So children who have been exposed to lithium in pregnancy do not appear to have the same amount of essentially brain damage that that babies who are exposed to valproate, for example, do, and some of the other mood stabilizers. So it's a tricky thing you're balancing. If this was a woman with a single manic episode who's really been rock solid stable, It may be, she may want to try to come off the lithium, or to see if something like lamotrigine actually stabilize her, which does have a better safety profile, but isn't, not everyone responds to lamotrigine in the same way. So it's great that she's talking about it well in advance. I'd be happy to talk about the case with you in more detail, but it's definitely one of those risk issues.
Ralph?
Yeah, I was going to comment on the questions about lithium. Early on, we were first doing it, there was concern it was possibly carcinogenic and a whole bunch of fears about it. I would say over time, the rate of abnormalities has been consistently going down. I think the best study is one in Rotterdam Steve Kushner was involved with, and the rates are very low, and it's a question, I think you said it correctly. If there's one episode, you might try to do without it. But basically, there's a lot of mythology about the risks with lithium, number one.
Absolutely.
But the second myth to possibly debunk is that in the past, it was said that if you had a postpartum depression with the first child, you were likely to have one with the second one. And I think that's been also debunked. Is that fair to say?
You have a higher likelihood than someone without a prior postpartum depression of having a subsequent postpartum depression, but you were still more likely than not to not have one.
But
So-
it's not a question to tell a patient, if you've had one postpartum, you shouldn't have any more children, which is
Oh,
what
of course
a
not.
number of people
Oh,
have
no,
been-
no.
have been told that. So
Yeah.
that was one of the
Right.
medical myths, along with some of the myths.
Right.
about
Well, that's part of the
this
whole purpose of this
debunking.
talk, so that,
Right.
so
Debunk some
that
of the
people
myths.
can, actually have children healthily, have healthy children. Yeah, absolutely. Thank you.
I'm afraid we're going to have to stop just because of time, but if you want to come upstairs for the luncheon, Betsy will hold forth upstairs and continue the discussion. Betsy, thanks, and keep up the good work.
Thank you.